Good morning, everyone, and welcome to our virtual UHKF Circle of Care presentation. I'm Evelyn Mason. I'm Chair of the Board of Directors of University Hospitals Kingston Foundation, and I'm pleased to welcome you all here this morning. Thank you for joining us. I hope you're all keeping well. The webinar is being recorded and will be available on our website and YouTube channel, and we expect the webinar to last approximately 45 minutes. There will be time for questions at the end, but you can ask a question at any time during the webinar using the Q&A feature. You were invited here this morning because you're among our most valued donors and volunteers, and we thank you for your continued generosity. Circle of Care events are held several times each year, and their purpose is to provide donors like you who are at the champion or ambassador who care annual giving level, our monthly donors, and our evergreen members who have confirmed a legacy gift, a special opportunity to connect with some of our outstanding healthcare and research professionals, one of whom is with us this morning. We're very fortunate to have Dr. Shirin Jalini, a stroke neurologist at Kingston Health Sciences Centre and Assistant Professor, Division of Neurology at Queen's University, with us today to talk about advances in stroke care and why seconds count if you're having one. Dr. Jalini's research interests include stroke prevention in patients with embolic stroke of unknown source and post-stroke epilepsy. Dr. Jalini, welcome. I will turn this over to you.
Thank you so much. So I'm just going to share my screen. Thank you so much for the opportunity to chat with you guys today. I have a little talk for you guys about the stroke program here at KHSC, which we're really proud of. I'm one of the 3 stroke neurologists here. There is me and 2 of my colleagues. And we have some other general neurologists that help us run our hyperacute stroke program. So during this talk, I'll just give you guys a brief outline of the basics of stroke, and then sort of what treatments are available and the recent innovations and what we're doing at KHSC. I will start. So the basics of stroke. So as you all sort of imagine, the stroke is caused by a problem in the blood vessels that carry blood to the brain. And the blood vessels that go from the heart to the brain are called arteries. And this picture sort of depicts the main blood vessels that go up to the brain. And the brain, like any other organ in the body, needs a constant supply of blood, which carries oxygen and nutrients and all of the good stuff that the brain needs to function. And there's specific arteries that supply specific parts of the brain. So it's all sort of mapped out. And what a stroke is that it's when one of these arteries is either blocked or it's burst. So we sort of compare it to plumbing. It's sort of pipes that carry blood, and then a stroke occurs when there's an issue with the pipes. So as a result, the part of the brain that is not getting blood starts to die. And that's basically what a stroke is. So there's different types of strokes. There's 2 principal types. One is called the ischemic stroke, and that's the most common type of stroke, 80%. And I call that the clotting type of stroke. And that's when there is a blood clot that gets stuck in a vessel and it plugs it up, similar to when a pipe is blocked and there's no flow. That's the most common type. The second type, it's called hemorrhagic stroke, and that's 20% of stroke, and that's the bleeding type of stroke. And that's when there is a blood vessel that bursts and basically blood starts going into the brain. So I'm going to focus on the ischemic stroke, the most common type of stroke, or the clotting type of stroke. So how is our society affected by stroke? Stroke is a major medical problem. There's some sort of statistics that have been coming out which state that stroke rates in our population are on the rise. Currently in Canada, every 5 minutes, someone is suffering from a stroke. It is the 3rd leading cause of death in Canada, and it can occur in any age, but the risk increases as you get older. So 1 in 10 adults over the age of 65 have experienced a stroke. And women are disproportionately affected by stroke throughout their lives. So that's some bad news, but some good news is that progress in stroke care over the last 2 decades have really been monumental, and that's what I want to highlight today. Just over 30 years ago, when someone had a stroke, there was almost nothing that could be done for them, and this has now completely changed. Today, there's so much that can be done to treat stroke and to support patient recovery. So what has led to this monumental change? Well, there's a bunch of things. So improved public awareness and symptom recognition. So now we've put out something called the F.A.S.T campaign, which tells the general public what to look out for. So if your face is droopy, if your arm drifts, if your speech is altered, you're supposed to call 911. So F.A.S.T, F for face, A for arm, S for speech, and T is time to call 911. And that has led to patients themselves recognizing in themselves or in others when somebody could be having a stroke and calling 911. There's better prevention now. There's revolutionary new life-saving treatments, and there's wider access to rehab programs after stroke, and there's increased community supports. So I'm going to tell you about the revolutionary new life-saving treatments because that's always fun. So the thing to understand with stroke is that, and this is something we say all the time, time is brain. So when you're having a stroke, time is of the essence. You have to act quick or fast. So, and the reason for that is because when a blood vessel is blocked, the brain tissue starts to die very quickly. And that rate is estimated to be about 2 million brain cells dying every minute. So this is why it's important to act quick, because you can imagine how many brain cells are dying as you delay. So the quicker we can open up that blood vessel and restore the blood flow, the less brain tissue is damaged and the better the patient outcomes are. And again, it's sort of like plumbing. There's a tube that gets blocked and we have to open it up quick. So I'm going to take you through what happens when somebody has a stroke. So let's say somebody falls at home, their family member hears the bang, they walk in and they see that they're down on the floor and they call 911. EMS gets there and the paramedics, they have a prompt card that helps them establish symptoms of stroke, and they use it. And they say, you know what, these symptoms are consistent, could be consistent with stroke. They ask the family, when's the last time this person was normal? When's the last time you saw them well? And that's called establishing the last seen normal time. And that's important because it helps us know what type of treatments we can give them. Then they do something called pre-notification. So they call the so when they load the patient into the ambulance, they call the emergency room and they tell them we have a code stroke coming and we're 30 minutes away or 10 minutes away. And this pre-notification allows the stroke team to be there and be waiting for the patient and be prepared. Because again, remember, time is important. So in the emerge charge nurse activates a code stroke through the hospital switchboard. And this hospital switchboard fans out a page. So they call all of the physicians, the residents, the radiology department, the nurses, everybody who's going to be potentially involved in taking care of that patient. And they'll let them know there's a patient that's coming in X number of minutes. And this is typically what we look like. The stroke team, which is the stroke neurologist, so myself and the resident, we're usually there waiting before the patient even gets there in the emergency department. So now the patient arrives and we sort of imagine it as this sort of multitasking thing. So we're all doing everything all at the same time to make sure things are happening quickly. So the patient rolls into the emerge, they get registered. The unit clerk calls CT and tells them the patient is here, get ready. There's a nurse that starts the IV and does blood work. There's the stroke attending, such as myself, and I listen to the story from the paramedic to know what's happened. And we usually have a resident or another member of the team who's performing a quick neurological exam. And all of this typically takes about 5 minutes. So it's a lot of things happening in a short period of time and in parallel. Then we go to CT, and our aim is to really start taking the CT within 10 minutes of when the patient gets there. So we move the patient to the CT on a paramedic stretcher. During the walk from the emerge to CT, we deliberate because one person's gotten a story, one person has done the exam. And so we sort of put our heads together and we find out what the other person has found, and we check key findings. Then the paramedics leave, we moved to the CT imaging area. And at that time, we usually call the family to get more information, because that's always helpful to hear it from family themselves. And then at that time, the person starts getting their imaging and we think, how should we treat this patient? So what are the treatments that are available for stroke? So it all depends on how quickly can we open up the blood vessel. So there's two main types of treatments. One is called thrombolysis, and this is the clot busting medication that has been around for many years. And what this essentially is a strong blood thinner, and it aims to break up the blood clot. I sort of think of it like Drano. Your sink is plugged up, you put some Drano and you hope that it works. So this medication can be given within 4.5 hours of symptom onset. So after that, we can no longer give it. So that's why it's important to act quick and to know when the last time the person was normal was. And this medication, just like Drano, sometimes it works and sometimes it doesn't. It's not a 100% thing. Usually, bigger clots are more difficult for this medication to break up. So this medication works well when there's a small blood clot that's pretty far out in the brain. For those type of strokes, this medication does well. And the goal throughout the world in the stroke community is to give this medication within 30 minutes of when somebody has arrived in the hospital. The second type of treatment, and this is the sort of newer one, is called EVT, or mechanical removal of the blood clot. And so this is an emergency procedure that removes large blood clots inside the brain. So it's a procedure that's done by the interventional radiologist, and it's sort of like plumber. So this is when you call your plumber to come and actually physically remove the problem. So this treatment has a bigger time during which it can be offered. It's within 24 hours in select cases. So it involves inserting a little catheter through an artery in the groin, very similar to how you would get a coronary cath or get a stent in your heart. And a small device that's fed all the way up to the brain, and then the clot is mechanically taken out. It's usually done under procedural sedation, so we don't use general anesthesia. And typically it takes anywhere between 20 minutes to an hour, hour and a half. And the blood clot is physically removed through suction or with a device. The aim, again, throughout the world is try to start this procedure within 60 minutes of when patients come to the hospital, because again, time is brain. So this is sort of an angiogram. This is what it looks like. So this is the blood vessels going up here, and you can see there's a little cutoff here. The blood seems to stop. So this is typically what the blood vessels look like when we start the procedure. And then when we remove the blood clot, you can see here that there's blood flowing to the rest of the brain. And this is what I was just telling Evan, this is what the New York Times main page was this morning. Revolutionary stroke treatment will save millions of lives. And so this is now starting to become more, there's more PR through mainstream media because it's such a revolutionary treatment. So we've been doing this since 2017, and I'll tell you our story. So we started off a pilot phase of this treatment in 2017 after a series of clinical trials showed that this procedure can dramatically improve outcomes and reduce mortalities in patients who are not responding to other types of stroke treatments. During this pilot phase, we treated a number of patients, and in the patients that we treated, the results were really impressive. And they were in line with the trials that were done. And we saw instances where patients would come in and they're completely unable to move one side of their body, and they're mute, they're unable to speak. And within minutes of the procedure, they were back to normal. They were talking, shaking hands, could walk, and they could even be discharged home the next day. We'd never seen anything like this before in stroke. And these were patients who are experiencing the most severe types of stroke. And before this procedure, these patients would have been left with severe paralysis, a lot of deficits, and even would have died. And this, they recovered overnight, back to normal. After this pilot phase, we were impressed and we wanted to implement this program widely to ensure that everyone in our region has access to it. You can imagine that was challenging because it required coordination and cooperation between multiple departments within the hospital. So it required coordination between the emergency department, the radiology department, the interventional radiology division, critical care, and the neurology and neurosciences. And also because we are the regional comprehensive stroke center, we had to coordinate with the 5 paramedic services and our partner hospitals in the region. So just you can see, Kingston in Frontenac County is the comprehensive stroke center for an entire region. So all the way Lanark, Leeds and Grenville, Lennox and Addington, and Hastings. So we are the one center that offers this procedure for all of this population. And we want to make sure that everybody who's in our catchment area is able to access it. So that required a lot of planning and a lot of meetings and coordination. So this partnership and a lot of hard work allowed us to really revolutionize stroke care across this region. So I'm going to tell you a story, Brendan's story, and Brendan has kindly agreed for us to share his story with everybody here today. So Brendan is a 31-year-old. He plays hockey. And in 2021, he had traveled from Perth, where he's from, to play a game of hockey in Kingston. Partway through the game, he suffered a stroke. And so he says, I started to feel dizzy and I decided to leave the ice. And when I was leaving the arena, I noticed that I was veering to the left while walking, and it seemed to be getting worse every 30 seconds. So Brendan knew the common signs and symptoms of stroke, and sort of through that FAST thing, the drooping face, can't raise your arms, the slurred speech or jumbled speech, but he didn't have any of those. He had dizziness. So he didn't think he was having a stroke, but he wasn't feeling well. So they brought him to KGH. So he was brought on and he was assessed initially by the emergency room physician, because again, nobody thought he was having a stroke. The emergency doc said, well, his left arm isn't working too well. His eye movements are not normal, and his speech was slurred. And the emergency room physician that said, wait a minute, this could still be a stroke. And at that time, called us. So we rushed in, and a code stroke was activated, and Brendan received imaging that showed that there was in fact a blood clot in a small vessel inside his brain. And luckily for him, he was able to receive that clot busting medication, TPA, which is given within 4.5 hours. So of the 47 Ontario hospitals that give this medication, KHSC is the only hospital to have achieved the 30-minute door-to-needle time. That's the gold standard. We are really the leaders in Ontario at how fast we can give this drug. And this was mentioned in the 2001 Auditor General Ontario report, that we are the only centers that's achieving target. And that's a real testament to the dedication of Callie Martin, our program manager, and Dr. Algin, who's our medical director, for setting us up to do so well. So when the clot busting medications was given to Brendan, it dissolved the blood clot in his brain. But he had a complication. A small piece of the blood clot broke off and traveled somewhere else, went more distal, and it went into a large vessel, causing for him to have another stroke when he was back in the emergency department. And what he says, he remembers wondering what was hitting. So I remember wondering what was hitting my leg and realizing that it was my own left arm, which had suddenly gone numb and I had no control over it. So the nurses alerted us, and another CT scan was emergently done and showed that another blood clot was in his brain. And this time it was in a location that could lead to catastrophic progression of symptoms. But luckily, where it was accessible by EVT. So the stroke neurologist who was on that day, Dr. Al Jin, called the interventional radiology team, and Brendan underwent emergency EVT by Dr. Ben Masari to remove the blood clot that was inside his brain. So KHSC is one of the 11 centers in the province to offer EVT, and we are the only hospital that has consistently met the target of starting the procedure within 60 minutes of arrival. We are the fastest center in Ontario for both the clot busting medication and for EVT, which we're really proud of, because in stroke, time is brain. So the next thing Brendan remembers is waking up in the intensive care unit. From there, he had an 8-day stay at the Kid 7 stroke unit. And this stay was a little bit longer than expected. We usually have our patients stay with us for about 5 days, but his was a bit longer than expected because he had uncontrollable hiccups for about a week. And that affected his ability to eat and drink. And hiccups are a common side effect of the type of stroke that he was having. We were able to control his hiccups, and he was happy to move along on his road to recovery at Providence Care Rehab, where he received stroke rehab to improve his walking and the use of his left arm. 13 days later, he was able to go home with the supports that he needed to help his healing. He had physio, OT, and home SLP that would come to his home and help him do things differently and to work on it. And I spoke to Brendan 2 days ago, and he's now back at work and doing great, but he's no longer playing hockey. So what his quote was is, "I appreciate the teamwork that it took for all of my healthcare workers to respond to my medical emergency and get me walking again without a walker and help me slowly improve how I can use my left arm." So, and it really requires a team. This is the team that is required to treat a stroke patients. So paramedics, the hospital switchboard, the emergency doctor and the nurses, the unit clerk, the CT tech and the radiologist, the neurologist and the neurology residents, the interventional team, the post-admission nurses, our amazing allied health, occupational therapy, physio, SLP, the rehab team where the patient goes on to Providence Care after, and of course the patient and their family themselves. And really, this is what Brendan said, the collaboration needed in stroke care is very similar to the teamwork needed to succeed in any team sport. So looking at our capacity and growth, this is a graph showing the number of patients here on the y-axis, and the x-axis is in the year. So starting at 2012, going up to now. The gray lines are the total number of stroke patients. The orange is the admitted number of patients, and the blue is patients who come in with a minor stroke and are discharged from the emergency department. What this graph is supposed to show you that stroke volumes are increasing. So about 10 years ago, we were having about 500 patients admitted or seen by our stroke team. Now that's over 1,000. So in the last 10 years, we have over doubled the number of patients we're seeing. And that's sort of seen across Canada. Stroke is on the rise. And then looking at EVT, our volumes again are increasing. So when we started this in 2017, we had about 36 or 37 cases we did that year. This year, we project to do over 100 cases. So you can see in just 5 years, we've gone from 30-something cases to 100. And we do expect this to sort of continue this growth, which is good news, because what it's telling us is that we're providing access. People are having access to this procedure across our regions. And this is something we're monitoring because we want to make sure everybody has access. So we do expect growth. By 2030, 30% of our population in Southeastern Ontario will be over the age of 60. And we do expect a dramatic rise in the number of patients who will have a stroke. So we have to prepare for this surge of patients. And this is the main thing. We need people. In Canada, stroke care and stroke education faces challenges, including a vast geography, regionalization of healthcare system, and a shortage of stroke-trained physicians in the community and rural setting, and especially amongst our Indigenous communities. Within Canada, there's only about 100 stroke fellowship-trained stroke neurologists. So think about it, only 100 people for the whole population. We need more stroke neurologists. So training the future generation of stroke physician is paramount to prepare for this surge and to maintain and further expand access to this life-changing treatment for everybody. So what we're doing about it this year, we joined other academic institutions in Canada to offer a rigorous curriculum-based nationally accredited fellowship program. So we enrolled our first fellow into our program this year. And our goal is to recruit physicians across disciplines, such as emergency physicians, internists, family doc hospitalists, and to provide them with some basic training in stroke care so that they can better serve their communities. And that is all I have for you guys today. I'm happy to take any questions.
In the Q&A, Diane Kelly wants to know, do the dead brain cells revive?
That's a great question. So no, the dead brain cells do not revive. They are basically gone. Once it's gone, it's gone. And typically stroke recovery happens not because the dead brain cells come up, because our brains are plastic. So other areas in the brain sort of help take over some function. But once a brain cell dies, it does not come back. And that's why it's important to act fast.
And Paul Murphy asked CT with a question mark. So I think he's asking what that is.
So CT is it's sort of a CT scan. It's a way to image the brain. It's a fancy type of X-ray where it gives us three-dimensional pictures of the brain tissue and also of the blood vessels in the brain, and can show us what's going on inside the brain and in the blood vessels.
What accounts for the increase in stroke over the past 10 years?
Great question. So lots of different things. So for one thing is we are seeing increased rates of stroke in the young, which is really concerning. So it's not uncommon for us now to see stroke in 30, 40, 50-year-olds. And the reason for that is, we're seeing more diabetes, more hypertension, more sort of risk factors in the young folks. So stroke in the young is increasing. Second is a large number of our population now is sort of moving towards being over 60. So as an age is a risk factor stroke. So the older you are, the more at risk you are. Third is, maybe people are having minor strokes and small strokes and they were just staying at home before and sort of managing. And we see this more in rural communities where people who don't have there's no public awareness campaigns to recognize subtle symptoms of stroke, would just sort of make do and continue. And maybe that public awareness is seeing more people come in and we're sort of capturing it. But sort of the main contributors are increasing age, increasing risk factors in our population.
Does stroke play out differently for younger stroke patients than older adults?
Great question. So in general, the treatments we can offer are the same. So stroke treatment is not ageist. We offer same treatments to patients no matter how old they are, but certainly younger people recover differently. I have a 22-year-old patient who had a massive stroke. And she was extremely paralyzed and disabled after, and she remained so for many months. But I see her a year later, and she's now walking and almost back to her normal life. And that's because a 22-year-old brain recovers differently than, let's say, a 90-year-old brain. And so stroke outcomes are different for younger people, but it depends on a lot of things: the size of the stroke, the comorbidities that person has, and lots of different things. But in general, young people do recover a little bit better than the elderly. I see Evelyn has a question here. How do you decide whether to use blood thinners versus EVT, and can you use both on the same patient? Absolutely. We can use both of those things in the same patient. So just like Brendan, our first decision point is, can we give the blood thinner, the clot busting medication? And the second decision is this person a candidate for the procedure? So those are made completely independently of each other. And so if the patient is eligible for both of those treatments, they do get both. If they're only eligible for one, they will get only one. And sometimes people are not eligible for either. So that's sort of what we need to decide.
Many older people live alone. How does this affect their treatment when paramedics can't readily learn when they were last normal?
Really good question again. So it's hard. That's a big challenge we face. When we don't know what's the last seen normal time, or when, then we can't give the medicine in most cases. But in the last year, actually, there is new studies that have come up that have said you can use a fancy type of imaging called perfusion imaging to select the type of patients who you don't know when they were well, but maybe you could look at the image and guesstimate. And if the imaging features line up, then you can give them the medication, or you can give them the treatment. And this fancy type of imaging is called perfusion imaging with a software called Rapid. And we do have that at KHSC. So, we have a handful of cases some years, over the last year, where we couldn't figure out, when is the last seen normal time? We don't know. And we look at the pictures and we say, we're just going to take a chance, because looking at these pictures, we think that this person still qualifies. So we sort of have to make those decisions based on the information that we have. But there is still hope for those type of patients.
Brendan had an effective arm and eyes, which would seem consistent with face and arms fast. So were his differences that atypical in their presentation that it didn't look like a stroke at first? Meaning, are stroke symptoms so similar, consistent, that even slight variations can be misleading?
So, so Brendan's initial symptoms when he was playing hockey was dizziness, and he couldn't walk. And so what was sort of and stroke evolves and it changes from minute to minute. So his initial symptoms were dizziness and can't walk. And that's what wasn't recognized as a stroke. Later, he developed more traditional symptoms, which was the arm weakness and stuff like that. So at that point, it was sort of more consistent with a stroke. But initially, that's why it wasn't, because it was pure dizziness. And, sometimes it's hard. There are atypical, the F.A.S.T acronym is not perfect. There are, other symptoms that can be stroke, but they're definitely more rare. So Brendan's case is a rare one.
Is there anything that can be done to prevent strokes?
Yes. So stroke prevention is another topic. So the most important things to prevent stroke is, controlling vascular risk factors. So blood pressure, blood pressure, blood pressure. That's the number one risk factor for stroke. So making sure that you routinely measure your blood pressure, and the target is usually less than 140/90 for people who don't have diabetes, and less than 130/80 for people who do have diabetes. And then, exercise and controlling diabetes, weight, diet, all of the main stuff that we do for heart disease, they sort of overlap. And that's how we try to prevent strokes.
Is total global amnesia considered to be a stroke or stroke-like? Does it require the same prophylaxis?
That's a great question. So transient global amnesia is a weird entity that nobody really understands. And there's various theories on what it is. Is it a type of stroke? Is it a type of epilepsy? And the answer is we don't know. But in general, we do not consider transient global amnesia to be a subtype of stroke. Because when you look at the data, patients who have transient global amnesia do not go on to be at increased risk of stroke compared to the general population. So it's its own thing. But we see a lot of it in our clinic because it can look like stroke. And so it is something we're quite familiar with, but it is not sort of thought to be consistently a subtype of stroke.
Is there a genetic component to stroke risk?
Again, good question. Yes, there are genetic causes of stroke, and they're huge. So there are particular genetic diseases that can increase your risk of stroke. So things like Marfan syndrome, antiphospholipid antibody syndrome. So there are lots of different genetic diseases that also come with stroke. But there's also genetic risk factors for hypertension. So we have a subgroup of patients who have early onset hypertension in their 30s, 20s, and they sort of have a genetic component for hypertension. And because hypertension is the number one risk factor for stroke, those patients go on to have more strokes. So yes, there for sure is genetic things that can cause stroke.
Would you recommend people take aspirin if they think they're having a stroke?
Ooh, really good question. I'm really happy you brought this up. And the answer is no, because when somebody has a stroke, it's hard to know if they're having the clotting type of stroke or are they having the bleeding type of stroke. And we can't even tell. I can guess, but really you need a CAT scan, the X-ray scan, to know which one it is. Is it the clotting or the bleeding? So until we know, it's good not to have aspirin because aspirin is a blood thinner. And if you're having the bleeding type of stroke, you probably don't want to be taking a blood thinner because that would worsen the bleeding. So in general, and we see this all the time, people are having something of a type of stroke at home and they're waiting for paramedics to come and they're given aspirin. Usually it's okay, but I would advise against that because at that point, you still don't know if you're having the bleeding type of stroke and you don't want to be taking a blood thinner.
Are dementia and stroke at all related?
Yes. So dementia is a complex disease of which there are different subtypes of dementia. But if you have a stroke, you are at risk of getting dementia. And dementia can happen also when there's a problem with the blood vessels of the brain. So there's a subtype of dementia which is caused by problems in the blood vessel. And certainly those folks are also at risk of stroke. So there is a relationship between stroke and dementia that goes both ways, but it's a complex one.
And the last question I have here, are cholesterol pills helpful?
Good question again. So cholesterol pills are helpful in preventing atherosclerosis or treating atherosclerosis, which is basically when you get, as we all age, we develop gunk around our vessels. It's just a natural part of aging, but also, if you're eating a fatty diet and such, you can build plaque around the vessels. And so those cholesterol pills can help. but they should be given as indicated, which means not everybody should take them. People who need them should take them. And so best to sort of let your family doctor or your stroke specialist or whatnot sort of guide you with regards to whether you truly need it or not. So as a blanket, does everybody need it? No. But in people who do need it, it will help prevent stroke.
Thank you so much, Dr. Jalini, for this informative presentation. Not only do we now know about the symptoms, we know what actions patients should take and what treatments are available. Thank you to you and also to the stroke team at KHSC. We're so very fortunate to have these dedicated professionals to help us in our time of need. This video will be available on our website and YouTube if you want to watch it again or share with friends and family. We would encourage you to take a few moments to complete the survey that you'll receive immediately following this webinar. Just some housekeeping measures. There's still time to play UHKF's 50/50 lottery. The deadline to get your tickets is tomorrow at 11:59 p.m. and the jackpot is $30,000. And my favorite campaign is coming up from May 1st to May 8th, and that's the Smile Cookie campaign, where cookies are available at all Tim Hortons, particularly in our area. And all the proceeds from the 14 Tim Hortons restaurants in Kingston are going to support child and youth mental health programs at Kingston Health Sciences Centre. Thanks again to all of you for joining us today. The next Circle of Care event is scheduled for June 21st, and it will be an in-person luncheon at the Cataraqui Golf and Country Club. Dr. Carolyn Tang, a cardiologist at KHSC, will be talking about her revolutionary work in non-invasive valve replacement. Look for your invitation to arrive in May, and I hope to see you there. So again, we appreciate your support, your financial support, and your emotional support of KHSC and UHKF and all the endeavors that are achieved. I hope you have a lovely afternoon, and thanks again. Thank you again, Dr. Jalini. Bye, everyone.
Thank you. Bye.